I would like to share with you a clinical case. This is a 49-year-old woman from El Salvador who went to dermatology department for a mole on the inside of her right foot. Biopsy revealed a lentiginous melanoma with a depth of invasion of 3 millimeters and a depth of infiltration of level 5. Melanoma was removed, but 4 years later a subcutaneous lesion appeared in the inner region of her right thigh. Additional tests revealed a metastatic melanoma. A molecular determination of mutations was carried out from the tumor biopsy and a BRAF mutation was detected. She was introduced in the sequential combination of immunotherapy and target therapy, the second-BEAT clinical trial for metastatic melanoma BRAF mutated, and was randomized to Arm A, beginning with target therapy with BRAF and MEK inhibitors such as encorafenib and binimetinib until progression of disease, in which case it is transferred to immunotherapy with checkpoint inhibitors, ipilimumab and nivolumab. 2 months later, metastasis improvement was found. The ophthalmic examination before second-BEAT was completely normal. But 6 months later, she had an acute anterior uveitis secondary to BRAF and MEK inhibitors and was treated with topical corticosteroids. According to the second-BEAT protocol, if uveitis is resolved in less than 21 days, medication should be kept. If uveitis is not resolved in 21 days, medication should be reduced or discontinued. 21 days later, our patient didn't improve, and oncology reduced the BRAF inhibitor but maintained the MEK inhibitor. 7 days later, uveitis was inactive, so medication was restarted at regular doses. 6 months later, the patient came to the emergency room with a red and painful right eye with a decrease of vision. Acute anterior uveitis was detected as long as cystoid macular edema in right eye and some cyst in left eye. Again, topical corticosteroids were restarted and oncology decided to discontinue BRAF and MEK inhibitors. In spite of that, the patient not only didn't improve but also worsened, and 3 weeks later visual acuity was very low. Anterior chamber inflammation was severe with 3+ cells, fibrin clots, and 360 degrees synechia, and there was vitritis in both eyes, and serous retinal detachment and optic disc edema in both eyes. You can see the macular OCT showing the serous retinal detachment in OD and the serous retinal detachment in left eye, and the optic disc OCT showing the optic disc congestion in both eyes. Treatment with oral prednisone and topical corticosteroids was prescribed. 7 days later, the serous retinal detachment and the optic disc edema had improved in both eyes, and 15 days later was resolved. Oral prednisone and topical corticosteroids were tapered slowly, but when prednisone was at 5 milligrams per day, cystoid macular edema appeared in both eyes, mainly in left eye. At this time, an intravitreal dexamethasone implant was prescribed in left eye. With that treatment, CME disappeared completely in both eyes. A biopsy of a right thigh lesion revealed progression of metastasis, so oncology decided to start with immunotherapy with checkpoint inhibitors, including ipilimumab and nivolumab. But 24 hours later, the patient came to the emergency room for decrease of visual acuity, anterior uveitis, and serous retinal detachment in right eye. An intravitreal dexamethasone implant was prescribed. 7 days later, serous retinal detachment had improved, but there was a new serous retinal detachment in left eye, only 1.5 months after the previous intravitreal dexamethasone implant. Oral prednisone was prescribed, and checkpoint inhibitor therapy was delayed. Serous retinal detachment were resolved in both eyes. At this point, second dose of ipilimumab and nivolumab was decided. But few days later, she went to the general emergency area because of a severe headache, hearing loss, and tinnitus. She was diagnosed with an immunomediated meningoencephalitis and was admitted to the hospital for intravitreal corticosteroids followed by high doses of oral prednisone. Of course, ipilimumab and nivolumab were stopped. 2 months later, we visit the patient and detected poliosis in eyebrows, eyelashes, and hair. OCT was normal and there was a moderate cataract in both eyes. You can see the difference 1 year later with respect to the poliosis of eyebrows and eyelashes. 4 months later, aside the poliosis, there was vitiligo. Poliosis was more evident, and the patient had diffuse choroidal depigmentation in both eyes. All of these findings were characteristic of Burko-Yanagi-Arada-like syndrome. So the key points of our case are the following. Anterior uveitis, cystoid macular edema, and serous retinal detachment can develop in patients with metastatic melanoma treated with BRAF and MEK or checkpoint inhibitors. Burko-Yanagi-Arada-like syndrome is more common with checkpoint inhibitors. They are usually bilateral and may appear at any moment of the therapy, so regular ophthalmic examinations are recommended. There is no need to discontinue the treatment unless persistent inflammation occurs, and therapy is usually with topical or regional corticosteroids, although oral or even intravitreal corticosteroids are required in the most severe cases. Thank you for your attention.